Hi, welcome everyone. I'll go ahead and get started just at 1 minute after, since we have a very packed agenda. I'm David Rakoff, the director for the Center for Population Health Sciences, and I'm very excited to welcome you all today. So many people that I want to thank for putting this together. First of all, Eileen and Sharu for really leading this pilot grant endeavor and setting up these meetings so we can really able to hear from you and hear the work that you've been doing over the past year and be able to share it with others. For the seven projects today, we're going to go through these quickly. I appreciate everyone participating, all of the grantees, and also for putting a year's worth of work in 5 minutes. I know it's a big challenge, and we appreciate you doing that so we can share with everyone what you've been working on. I also really want to acknowledge the Stanford Center for Clinical and Translational Research and Education, Spectrum, for funding these pilot awards. The focus is on accelerating clinical and translational research in biomedical and health-related areas. And at PHS, we focus these projects, as you'll see, on things that have a real high impact, on pressing community questions, really important questions for public health and population health, and all of these projects being related in some way or another to addressing health inequalities. So we'll have about 10 minutes at the end for Q&A. So please put your questions in the Q&A box. And with that, we'll get started. Apologies again to speakers. If you go over, we wish we had more time, but we'll just have 5 minutes for each speaker, and Sharu will be giving a warning on time if we need to. So without any further ado, I'd like to start with the first speaker, Giacomo Benini, who's a postdoctoral research fellow in the Department of Energy Resources and Engineering. Thank you.
Thanks. So can you all hear me? It's fine?
Sounds good.
Okay, great. So our project focused on natural gas flaring and venting. What's this? Oil and gas company very often look for oil. They find oil and gas together. They co-extract the two things together, and they very often don't know what to do with the natural gas. They either combust it on site. This practice is called flaring, or they release it in the atmosphere. This practice is venting. The United States are a particularly interesting case because all the recent oil that was found in northwest of North Dakota and at the border between New Mexico and Texas was not particularly well connected with the pipeline system, with the natural gas pipeline system. So companies combusted on site and liberated an enormous quantity of natural gas. And the question we were trying to answer with this project was, does this have an effect on respiratory problems? In order to answer this question, we constructed a data set who has a time dimension as is year. So we have a yearly resolution and a cross-sectional dimension that is the zip code. And then we merged information coming from different fields. We used the PHS Stanford data portal to collect how many visits in that zip code were related with diagnosis somehow linked to respiratory problems. We used NASA repositories to compute the speed at which the wind was going in that particular zip code, and we deconstructed it using octanes in a rather complicated way. And then we investigated how many flaring permits were required by companies who were operating in that zip code. And finally, we needed to estimate how much natural gas was vented because there is no regulation on venting. And this last number was very, very complicated to compute. And it took us roughly, the entire time of the project to simply compute this last column. Once everything was put together, we tried to estimate the causal impact of flaring and venting on respiratory problems. We couldn't simply regress respiratory problems on flaring and venting because the people who live the closest to oil and gas facilities tend to be associated with low socioeconomic conditions, which are also correlated with health outcomes. So what we did is that we came out with a 3-step estimation idea. In the first step, we regress the gas-oil ratio of the field of today on the gas-oil ratio of the field yesterday. If a field is 70% oil and 30% natural gas, every time you drill there, you expect 70% of output to be oil and 30% of the output to be natural gas. However, this is not always the case. Sometimes you find some bubbles. Sometimes, you know, the porosity of the reservoir changes in a particular part of it, and so you get more natural gas out or more oil. This delta that here you can see in epsilon has a very interesting characteristic. On one side, is very much correlated with the volume of flaring and venting that you do, because if you extract more natural gas than what you would expect normally from the GOR of the field, you will combust more of it and you will vent more of it. At the same time, it's completely independent from the socioeconomic condition of the people that live nearby. So we run the first regression, we get the epsilon out, and we can use this epsilon as instruments because they are correlated with what we want to model, but they are uncorrelated with the equilibrium condition that I was describing before. And so then we can use a 2-step estimation process in which we have first an IV regression, where we regress the wind multiplied by the sum of flaring and venting on these estimated instruments. And then we can regress the number of respiratory visits divided by the number of total visits in that particular zip code over the wind multiplied by flaring and venting as estimated by the previous regression. And if you believe this identification strategy, then beta 1 is causal. Okay, then beta 1 tells you by how much increasing flaring and venting by 1 standardized cubic feet increases the number of visits. The project is not finished. We're still in the process of completing it, but from our preliminary result, increasing flaring and venting by 1 barrel of oil equivalent per day increases the number of respiratory visits by 0.001%. And this is our final result.
Thank you. It's good to interesting to see that. I mean, is that well, there's so many questions. I forgot. I can't ask questions right now. We have to move on, but please put questions up there for Giacomo, and thank you so much for presenting. Next we see is Sam Heffneal, who's a research scholar at the Center on Food Security and the Environment. Welcome.
Thank you. Today I will be talking about health impacts of pollution that infiltrates indoors, a project joint with colleagues Marshall Burke, Lynn Handelman, and Gary Shaw. Today we'll be focusing on the pollution that infiltrates indoors part, with the health impacts part left for later. So there's been a lot of work studying outdoor ambient pollution impacts, but we know that Americans spend most of their time indoors. So our main question is how much of the ambient pollution actually filters indoors? And this is particularly important in the context of increasing presence of wildfire smoke, where the main policy response has been to tell people to remain indoors and protect yourself because it's really hard to stop wildfires at the source. And so we're interested in what are the average infiltration rates and how do these rates differ across groups? So we use a combination of information on hourly indoor air quality from purple air monitors that people purchase and put in their homes. We combine the indoor and outdoor monitor data so that we see hourly what the indoor air quality is and the outdoor air quality. And then we combine that with a data set from CoreLogic that gives us information on building characteristics, the age of the home, the size, whether they have air conditioning, as well as neighborhood demographics from the census that lets us understand the socioeconomics of the neighborhood. We're going to use this to estimate pollution infiltration rates. So when outdoor pollution goes up by 1 unit, how much does indoor pollution go up by? And how do these rates vary across groups? So one of our main findings is that the infiltration rates vary a lot across groups. And you can see in the top, in the raw data, it's very visible where looking at wildfire during a wildfire on the peninsula from 2021, the top map shows the outdoor pollution levels and the bottom map shows the indoor pollution levels. And you can see that across the peninsula, most homes are exposed to similar outdoor levels of pollution, but indoor air quality is hugely variable depending on the home. And we see these same patterns in our data when we estimate the average infiltration rate across the 1,500 or so homes that we have data for. We find that a 1 microgram increase in outdoor PM increases indoor PM by an average of 0.17 micrograms. So that's saying about 17% of outdoor pollution infiltrates indoors, but there's huge variation in our estimates where some homes have very low infiltration rates and some homes have very high infiltration rates, as shown in the distribution below. And we looked at a number of factors that affect infiltration rates. One of the big ones is the pollution level itself. We find that infiltration declined sharply with pollution level, which is consistent with the idea that when pollution is more salient, people are aware of it, then they change their behavior, shutting windows and doors, turning on air purifiers. And so we see the sharp decline. We also see differences for a given pollution level and whether that's from smoke or other sources. And this seems to be driven large part by the temperature differences, where wildfire smoke pollution events tend to happen when it's really hot and people have their windows more open, whereas other types of pollution events tend to happen in the winter where people are less likely to have doors and windows open. We were a little bit surprised to see that infiltration rates only barely decline with income. We thought this gradient was going to be much more sharp. And so we have these estimates for all these households, and we try to estimate a model that explains this variation, and we could not come up with a good model that could explain more than about 5% in the variation of our empirically estimated infiltration rates. So one of our takeaways is that it seems like unobserved things like behavior are really important. And why does this matter? Well, it matters because we have bad pollution events, and these infiltration rates dictate what your indoor air quality is. So looking at the homes around the Bay Area that we have data for, we divided them into high and low average infiltration homes. And then on the right, we plotted the daily time series for each home during the fall 2020 wildfires. The top shows the outdoor and the bottom shows the indoor, where the colors correspond to whether it's a low or high infiltration household, and the dark lines show the averages. And you can see from the top plot that outdoor pollution is relatively similar across all these households. But if you look at the bottom plot, you can see that for the high infiltration households, their pollution levels are often 3 or 4 times as high as the low infiltration households. So what the infiltration rate is dictates a lot of what the indoor air quality is. So our main takeaways are that pollution infiltration varies a lot across homes, even within the same neighborhood, and that these differences result in really large differences in indoor air quality during the biggest pollution events. And all of the observables that we have on house and neighborhood characteristics do a really poor job of explaining this variation in infiltration, which again suggests that people's individual behaviors matters a lot. So for our next steps, we've been working to equip homes with sensors that detect behavioral choices about turning on fans above the kitchen stove or windows and doors opening, as well as extending our home monitor network to more low-income homes, because our sample is self-selected of people who purchased monitors and put it in their own homes. And finally, we plan to link these indoor exposures to health outcomes. Thanks for your time.
Thank you so much. Very interesting, and interesting future work here as well. Next, I'd like to introduce Jonathan Young Lee, who's a clinical instructor in psychiatry and behavioral sciences, and a PhD student in health policy.
All right, thanks so much. So the title of my project is Trust Wars, Identifying Common Types of Rhetoric on Twitter related to trust in the CDC. Now, many of you have probably heard the term post-truth, and it generally refers to concerns about disputes over public truth claims. So just to highlight this for you using Twitter, you can imagine there are people out there tweeting that the truth is Biden stole the election. On the other hand, people saying Biden did not steal the election, or climate change is real, or climate change is not a real issue. Vaccines and masks work based on science, or vaccines don't work. And this can matter because exposure to such rhetoric likely is affecting behavior. And so, for instance, if you look at the percentage of people in each age range that have received the COVID-19 vaccine, we still have pretty suboptimal rates of vaccine uptake, especially among younger adults and children. And why might this be? Well, one reason could be that if you look at the people that are not vaccinated, they are much more likely to agree with the following statement. Public health officials are not telling us everything they know about COVID-19 vaccines. So essentially, it seems like there is some trust issues between the public and public health officials. So I'm particularly interested in drivers of source trustworthiness and credibility. And in the literature in general, there are two main components that seem to define source trustworthiness and credibility. The first is expertise and competence, referring to whether or not the source has the ability, the knowledge, the resources to know what the right answer is. And then integrity and benevolence, which if they know the right answer, are they going to tell us the correct answer? Do they have the right intentions, motivations, and influences? Or do they have ulterior motives and influences and potentially will mislead the public or lie to the public? Now, social media, as we know, is a major source of misinformation, and its use is also negatively associated with COVID-19 health protective behaviors. So naturally, I was interested in studying how might rhetoric on social media be affecting trust in the CDC? And so what I did was collected tweets that contain keywords related to trust, such as trust, credible, trustworthiness, and those related to the CDC, so CDC, CDC Gov, and after some filtering and cleaning, ended up with a corpus of 230,000 unique non-retweet tweets. And I then applied, after looking at various machine learning-based text analysis topic modeling algorithms, I applied one which essentially aims to cluster tweets that to the algorithm appear semantically similar. So for instance, I ended up with a cluster related to flip-flop, where all of these tweets appear to have keywords related to flip-flopping, flip-flop, flip-flop, flop-flip. Or a pharma cluster, where all the tweets appear to be related to CDC ties to pharma, or politics. It's political, it's politicized, there's political interference. And in this way, I tried to categorize these topics and map them onto the theoretical construct of source trustworthiness and credibility. So I ended up with 5 major topics. The first is ambiguous. It doesn't necessarily map onto either the expertise competence component or the integrity benevolence component. Ambiguous tweets are ones that seem to say the CDC is wrong, doesn't say whether they made a mistake or they're purposefully misleading you. Then there's the expertise competence component, which specifically are tweets that appeal to the notion that the CDC has or doesn't have expertise, contains experts, scientists, doctors, etc. And then 3 integrity benevolence topics. The first is ambiguous. So it says that it's not that the CDC is making a mistake, it's that they are purposefully misleading, lying, or withholding information, but it does not explicitly give a reason, an intention, or an outside influence. And then we have non-political and political versions of integrity benevolence tweets, where non-political version refers to the CDC having ties to pharma, profit motives, owns patents, Bill Gates conspiracies, or political. So specifically influence from Trump, Biden has been politicized, etc. And so when we summarize some of the findings in a graph, if you first focus on the gray bars in the background, which represent total tweets related to trust in the CDC, what you see is that prior to the start of the COVID pandemic, there really aren't that many tweets about trust in the CDC, but this skyrockets at the start of the pandemic, which makes sense. Now, specifically, if you look at the colored lines, the benevolence, integrity, political type tweets, this rhetoric is relatively low prior to the pandemic, but skyrockets at the start of COVID and remains quite high even after Biden has won the election. On the other hand, when you look at tweets related to expertise and competence rhetoric, that is relatively low prior to the pandemic and remains relatively low, which was somewhat surprising to me. On the other hand, non-political rhetoric, such as arguments about the CDC having ties to pharma or CDC owning patents or conspiracy theories, that's relatively high prior to the pandemic, but drops and appears to be somewhat crowded out by politicized speak during the pandemic. And so, one of the major implications of this, I think, is that public health institutions may be particularly vulnerable to integrity, benevolence type rhetoric, as opposed to expertise and competence. And even further, it may be in particular political motive or political influence type rhetoric that public health institutions need to be particularly concerned about and respond to. Ongoing research, I'm running online randomized controlled survey experiments where I'm trying to get causal evidence of the relative effectiveness of these various strategies at bolstering or undermining trust in public health institutions. And I've also received follow-on funding from the Vaccine Confidence Fund from the Alliance for Advancing Health Online to continue this research.
Excellent. Thank you. Thanks so much. Very interesting. Next, we have Stephanie Leonard, who's at the time she applied was an instructor, now assistant professor, or is it not yet official?
Fall quarter.
Fall quarter, soon to be assistant professor in obstetrics and gynecology.
Thanks so much. Our project was on identifying opportunities to improve health inequities for pregnant people. So the big picture motivation for our work is that the maternal mortality rate in the United States is the highest among high resource countries in the world, and unfortunately has been increasing over time, as shown in this figure. Further, there are disparities in maternal deaths that are both substantial and persistent. Shown here are data from the CDC showing that the rates are highest among people who are Black or American Indian, Alaskan Native. And the CDC in this report had identified potential causes of these disparities as access to care, quality of care, and chronic diseases. And our work has really sought to better understand and address these issues. The goal of this pilot project was to identify clinical opportunities to advance equity in severe maternal morbidity. Severe maternal morbidity is an established composite measure of potentially life-threatening complications that are related to pregnancy or childbirth, and it shares similar causes to mortality, but is nearly 100 times more common. Aim 1 of this project was to evaluate disparities in severe maternal morbidity standardized for comorbidities. To conduct this aim, we used California birth data that was linked between birth certificates, the birthing patient discharge data, and the infant patient discharge data provided by state agencies and linked by the California Maternal Quality Care Collaborative, or CMQCC. This includes almost all births in California, which were approximately 450,000 per year, which is the largest state in the country. And just to jump to the results for the sake of time, these figures are showing the incidence of severe maternal morbidity among various racial, ethnic, and socioeconomic groups in California. And the red bars are showing the crude SMM incidence, so before any type of standardization. And then the gray bars are showing what the incidence would be after standardizing for a very robust obstetric comorbidity scoring system that our team previously developed. And so if you compare these red bars, you see the disparities in crude rates. And when you compare the gray bars, you're seeing the disparities after adjusting for underlying health conditions. And for the sake of time, I just draw your attention to that one, there are just significant racial and ethnic differences both before and after standardizing for this comprehensive comorbidity score, and that the incidence among people who are white is significantly lowest both before and after standardizing for comorbidities. So a main takeaway from this work was that health inequities both during and before pregnancy strongly affect, but do not fully explain disparities in severe maternal morbidity. The second part of this pilot project was to assess the contribution of differences in labor and delivery practices to disparities in severe maternal morbidity. We similarly used the same linked California birth cohort, but this time we started a collaboration with a group at Yale who had done an obstetric practices survey. So they surveyed 185 hospitals in California about their labor and delivery practices. And we linked that to the California birth data for the survey years. And then we also restricted to low risk births. So people who had a very low risk of having a major complication at birth. And so one of the findings we had was that one, most people gave birth at a hospital that had higher interventional practices. And this was significantly more likely among people who were Black or Latinx Hispanic, as well as people who were had public insurance. However, we also conducted a mediation analysis and found that this difference in high versus lower interventional hospitals did not contribute to disparities in either severe maternal or neonatal morbidity. So the takeaway here was that delivery at hospitals that tended to use high interventional obstetric practices was most common among Black and Latinx Hispanic people and people with public insurance. and that hospital variation and high-low interventional practices did not appreciably affect disparities in severe maternal or neonatal morbidity. And together, all these findings are very informative for interventions and other quality improvement initiatives that are working to improve equity in obstetric health. Our areas of future investigation that we're pursuing are 1, examining within hospital disparities in obstetric care, 2, characterizing hospitals with higher and lower disparities in obstetric health outcomes, and 3, evaluating variation in obstetric health outcomes within socially marginalized subpopulations. And I would very much like to thank our funding from Spectrum PHS as well as MCHRI, our study data, as I mentioned, and then our really wonderful big team of collaborators. And I thank everybody and welcome your questions and comments later on.
Thank you so much, Stephanie. It's really important work. Great to see this. Next, I'd like to introduce Alice Milivinti, who's a postdoctoral research fellow here at Stanford.
Thank you. So today I'm talking about the project called A Healthy Surrogate, Predicting Long-Term Effects from Short-Run Policies. As we know, policymakers, when they do policy experiments or they start policy experiments, they would like to see the effects and if the policy reaches their targets in a very timely way because they have to justify their budgets. But what usually it looks like for a policy to get to the target is not very directly, is more involved. And it usually takes a lot of time to evaluate, especially when we are looking at outcomes that are not very volatile and long-term effects of the policies that are often the target of those. And waiting the time to evaluate the policy is very costly. So one of the alternatives or the solutions that we propose and we investigated in this project is to find some intermediate outcomes or targets that allows us to look at the trajectory of the policy stepwise and to finally see how the policy reached the long-term targets. And this is not super fast, but it gives result in a more timely way and probably efficient way than waiting for all the long-term conditions that the policymaker wants to target at the end. So the policy that we analyzed is state earned income tax credit because these policies allow some quasi-experimental variation across the different states because some states implemented it and some states did not implement it. And what we looked at, we were looking at chronic conditions and we tried to find some intermediate outcomes that can help us to link the effects of these state earned income tax credit to more long-term health problems. And we combine these surrogates into an index. Usually the surrogate index is, there is some trade-off between the number of surrogates. It should be bigger than 1, but also it shouldn't include too many indicators or temporal indicators in order to be as efficient as possible. And the data that we are using, thanks to the PHS team, we are using data that are at the PHS data portal that is called American Family Cohort. These are electronic health records that include demographics of the patients, health behaviors, vital signs, lab orders, diagnosis, and medications. This was a pretty, let's say, new or not so much use yet for research. So we had the opportunity to explore the potentiality of this new data, but it also, we encountered some challenges in terms of data cleaning. And so the first step, the surrogate index are a 2-step procedure. In the first step, we select the chronic condition that we are interested in, and we run regressions or some analysis on a large amount of surrogates in order to identify which ones are the most informative in terms of chronic conditions. And this can be implemented with different techniques. Of course, with big data, machine learning like lasso type or random forest can also be implemented. But for the moment, we only did some stepwise linear regression. This is for the future. We hope to implement more sophisticated machine learning algorithms. And what we saw, so we analyzed the earning context credit on hypertension, is one of the first chronic conditions we are targeting. And we identify some of the surrogates that gave us just the best fit of the model with not particular interest in causality. We are just interested in the time, in the sense that when hypertension is diagnosed and when the surrogates or the short-term outcomes are also diagnosed for the patient. And once we estimated and we found our best fit model, we created this surrogate index of intermediate outcomes, and we regress the predicted surrogate index on the state earned income tax credit. So if the individual that is living in low income census tracts is also in a state that benefit from the state earned income tax credit. Unfortunately, for the moment, we haven't found, or unfortunately, for the moment, we haven't found any significant results, but we hope in the future to continue our research and find other interesting results, because these techniques can leverage big data, can help policymakers to take their decision in a more timing way and save money. And also the long-term goal of the project is to look at other and create other surrogate index for other chronic conditions and maybe even other policies. Thank you very much.
Thank you, Alice. Great to see how this work is going. Next up, we'll have two presenters, Francis Perriman, who's an assistant professor in the Graduate School of Education, and Lily Steyer, who's a PhD student in the Graduate School of Education. Thank you.
Hi, everyone. I'll kick things off. I'm excited to tell you about a project that Alvin, my co-PI, and I have been working on, looking at residential instability in the unaffordable city, consequences for child mental health. So as many of you may be aware, the US at large and US cities in particular are facing the worst affordable housing crisis in generations. And specifically, the majority of poor American families now devote more than half of their income to housing costs. And as a result, these families are acutely vulnerable to involuntary housing moves due to a lack of financial resources. And prior research has found that families with children are especially vulnerable to these types of forced moves. And as this headline suggests, people are aware, at least anecdotally, of the potential mental health effects of residential instability, but surprisingly, the empirical research on this topic is relatively thin, especially when it comes to the mental health consequences for children. So in this pilot project, we set out to answer two primary research questions. The first is about prevalence. So what proportion of urban children experience residential instability before their 10th birthdays? And then second, impacts. What is the effect of residential instability on child mental health? And to answer these questions, we draw data from the Fragile Families and Child Wellbeing Study, which is an ongoing nationally representative study of roughly 5,000 kids in US cities. And by design, Fragile Families oversamples disadvantaged households that we might expect are especially vulnerable to residential instability. And we apply propensity score analyses and use child mental health at age 9 as our primary outcome. And specifically, we look at two mental health outcomes, child internalizing behaviors, which is a measure of anxiety, depression, and withdrawal, and then child externalizing behaviors, which is a measure of aggression and impulsivity. And so what do we mean by residential instability? In this pilot, we're focusing on 3 forms of residential instability that are known to be increasing in recent decades, especially amongst households with kids, and that are tied to the housing affordability crisis. So the first is eviction, or when families are forcibly removed from their apartment or their home by their landlord or mortgage lender for failing to pay their rent or mortgage. The second is homelessness, which I imagine folks are pretty familiar with. And then finally, doubling up, or moving in with others, either relatives or non-relatives, because a family can no longer afford their home. And with that, I'm going to turn it over to Alvin to share some of what we've found.
Yeah, great. Thanks, Lily. I just want to highlight four key findings from this work thus far. Some findings somewhat expected, some somewhat surprising. First key finding, forms of residential instability that Lily just mentioned are most common amongst traditionally disadvantaged populations, right? So we're talking about children of color, low-income children, children of renters, right? Are at elevated risk for each of these forms of instability. Next slide. Second, rates of instability are similar in gentrifying as well as persistently disinvested neighborhoods. This is one of the somewhat counterintuitive findings that we observed. But what we're observing there is that children who live in neighborhoods that are low income to begin with and continue to be low income over extended periods of time, they face similar rates of residential instability than do children who live in neighborhoods that subsequently gentrify, right? And we can talk a little more about sort of the context for that finding in the Q&A. Next slide. Third key finding is doubling up is by far the most common form of instability amongst U.S. children. For some subpopulations, rates of doubling up are 3 and 4 times as much as they are for rates of homelessness and as well as eviction. Next slide. And then the last finding, as Lily mentioned, the second research question was about the implications or the impacts of different forms of residential instability for children on their mental health, right? And we focused on two outcomes: internalizing behaviors and externalizing behaviors. And what we find overall is that residential instability in general is bad for children's mental health, right? Children who experience homelessness, who experience eviction, children who find themselves doubled up with other families, have increased externalizing behaviors as well as internalizing behaviors nearly across the board. Next slide. So the real world implications for this work, forced moves are a common life event for disadvantaged children in contemporary urban America, as Lily opened up describing. Getting evicted, becoming homeless, and being forced to double up are harmful for children's mental health. And these findings overall just underscore the need to really conceptualize the housing affordability crisis in U.S. cities, not simply as a housing related issue, but also as a public health issue. Next slide. So future directions, I think some presenters already described the AFC data set. We too will be using the AFC data set in subsequent studies. This will enable us to examine policy impacts more directly. We're also interested in longer term and like cascading effects. If a child experiences an eviction, subsequently experiences homelessness, right? What are those cumulative type of effects? We're also interested from a developmental standpoint on issues of timing as well as dosage when these forms of instability take place during children's sort of early life course. Also note that Lily was recently awarded a Data Science Scholars Award for continuing this work. And I work in the Graduate School of Education, and we just launched a new Center for Early Childhood Education that will provide a captive audience for the next few years as we continue to develop this work. And we will stop there. Thank you.
Thank you both. Great to hear about those future directions too and see what you found. Finally, we next have Gabrielle Wong-Parati, who's an assistant professor in the Department of Earth System Science. Welcome.
Great, thank you. So I'm going to talk about some of the findings as it relates to the Our Communities, Our Bay pilot project work. And this is a 2-phase pilot study to inform the design of a longitudinal study testing the effectiveness of affordable interventions to reduce wildfire smoke exposure and health risks among low-income, predominantly non-English speaking households. And here you can see the project team work really closely with their community partners as well as with a team of researchers here at Stanford. So the communities that we focused right here in the San Francisco Bay Area. So we focused on Redwood City, North Bear Oaks, Bellhaven, and East Palo Alto. Here you can see that the communities we focused on are frontline communities. So those that experience the first source of climate impacts. And with respect to the first phase of the study, this was really about identifying and developing interventions. So right up to the point where we started to initiate the pilot study, which happened this past fall and winter through the spring, we did interview studies. We worked really closely with our community partners. We recruited 13 community ambassadors to help us with recruitment, enrollment, and conducting the pilot study. And through this initial work, we were able to develop and refine an app that is called the Our Communities app, which provides community members with information, real-time information about risk, ways they can mitigate their risk, as well as an opportunity for us to push out surveys in real time to identify what people are thinking, doing, and feeling, and the symptoms they may be experiencing as they're exposed to threats. We also identified, in collaboration with our community partners, the air cleaner that would be the low-cost, affordable intervention that we could deploy. And it was here really important that it had high energy efficiency to lower cost burdens, as well as were not noisy. We also were considering weather stripping intervention. This initial work was really important to recognize that there are a lot of community concerns, especially as it relates to relationships between potential undocumented residents and our frontline communities, as well as fear of gentrification and getting pushed out of homes if we have something that would be a structural improvement. So that work really important, identifying that weathering as an intervention to study was something we were not going to do. And then we moved into the second phase of this work, which was a pilot study, really intending to validate protocols and to test the equipment. As I mentioned, we did it this past kind of fall, winter through spring, and we did it with 30 households that were recruited by our community ambassadors. We did significant co-location testing of the purple air sensors that we were using to assess indoor air quality. And we did testing of the app to implement surveys, and we also did exit interviews with each of our participants. And so one of the things that we learned, and I think this echoes some of the findings that Sam highlighted earlier, was the state of the indoor air quality of our pilot participant households. So here you can see a screenshot of the study area where purple air sensors were already located. And then you can see where we were able to implement and install purple air sensors in our communities. And you can see that we're installing in locations where there basically has been no data collection before. And what we found is that for many of our households, the indoor air quality was much worse than the outdoor air quality. Just like Sam was highlighting, a lot of this has to do with behavior. So we also got insights from our pilot participants when we did exit interviews. And what we found is that people were saying project ambassadors were really helpful for the participants to understand the different technologies that we're using and to feel really comfortable with the study in general. And that participants wanted to join the study because they saw the benefits for themselves, but also were really caring about the community at large. So in the future, we are actually, I should say in the future, right now, we're currently recruiting up to 420 households in our 4 communities. We're going to do a randomized controlled trial of different variations of the treatments that we're looking at, both message-based as well as that air cleaner treatment. And we were able to procure funding from Environmental Protection Agency to support this work. And right now we're working on 4 papers. One is outlining the pilot process. Another is going to be really focused on community engagement and how we did it and how to do it from a theoretical perspective. One's focusing on our community app that we developed for the study. And a 4th is looking at purple air sensors in frontline communities. And we are also collaborating with the Tule River tribe to replicate portions of this study with them in the Central Valley. So thank you for your attention. I'll answer any questions if anyone has any.
Wonderful. Thank you. Thank you so much for this work and for taking the time to share with us. Thanks for everybody for sharing with us today. So we had a few questions that were posted already. One was answered, but let's see. for the question, okay, so there's a question for Sam. Are homes affected with higher indoor pollution by type of home or year built? Sam had a very complete answer there. This is awesome. Do you want to just highlight a few things for everybody?
Sure. I think one of our main findings was just that home characteristics do matter, but much less than we expected. And so to Gabrielle's point, we really couldn't explain much of the differences in the pollution infiltration from housing characteristics alone. And so one of our conclusions was that behavior is really important. And one caveat also to Gabrielle's point is that our sample is only people who have purchased indoor air quality monitors to put into their homes. So we expect that subset of the population to be kind of more aware of air quality and more able to protect their indoor environments than most. And even among that population, we see a lot of these homes have really done a poor job at protecting their indoor environments and have really terrible air quality during wildfires. And so even if this population can't protect themselves, I think that is really concerning when we think about the more general population.
And I'm sorry if I didn't catch that. Were you really kind of conditioning, the focus on wildfires, kind of conditioning out other sources of indoor air pollution that are coming in the home, or is that kind of part of it as well?
Yeah, so I skipped over that entire part, but we have a statistical model that we use that is designed specifically to try and filter out the types of indoor air pollution so that we think we're controlling for that effectively.
Okay. Well, here's a related question, either for Gabrielle or Sam. Do cooking habits affect indoor air quality, or is the greatest concern smoking indoors?
Yeah, it does. Cooking affects it greatly. So we actually see spikes when people are frying foods and things like that. Smoking also contributes as well. And to that point, we're trying to control for as many possible confounds as possible. So we've recruited non-smoking households, but we are also assessing cooking behavior.
There was another question here for Alvin or Lily, suggestions on changing. I'm not sure I totally understand that question. Can you see it? Suggestions on changing the bar colors. Maybe if you want to talk through your results a little bit, I think there was a suggestion, but just talking through some of those findings a bit more.
Yeah. Thank you for the comment, Lydia. It looks like it was just a suggestion about how we can visualize the instability rates a little more clearly, and there was plenty more on that visualization that got kind of mixed very close to the presentation. But I take your point. We'll try to make that a little more colorful and a bit more compelling. The thing that I will note, I think there was really three categories of interest. You had child level factors that we were really interested in, but we also and as well as family level factors, but also neighborhood level factors. And one dimension that I didn't highlight during the presentation was simply the elevated rates of all forms of instability in residentially segregated neighborhoods, right? So neighborhoods where there's elevated shares of Black, elevated shares of Latinx residents, all of those rates of instability spike in those communities as well.
Thank you. Other questions from that other folks have, or panelists to each other? While you're thinking a little bit, I had a question. One of the questions that came up for Giacomo at the beginning. So at the very end, I know it's a bit preliminary, you had sort of that estimate of the impact, and it was tough to get a sense of, whether you considered that very null because it was very small, or if you think about the dose and the number of people exposed, whether, you're generally thinking this seems like a significant or meaningful exposure.
The number seems very, very big to me. Maybe too big. That's because the explanatory variable was moving by 1 barrel of oil equivalent per day, which is very, very, very small. You can have tens of thousands of that per day. The impact seems very big. but it might be very, maybe in the presentation it came out wrong in the sense that I kept the unit of account of the explanatory variable so small that the percentage of the dependent variable looked very small. With
I caught the one barrel, but I just wasn't sure
yeah,
how
no,
that,
it's very small. So
Yeah.
it could be potentially very big, unless we have made a mistake in the calculation.
I had a question about the indoor air pollution. I thought it was interesting that we weren't able to explain variation very much, and obviously that speaks to the role that behavior plays. And I was just curious about like proxies for behavior, right? That might be predictive. One simple one that came to mind is like how often people wear masks, like face masks. I feel like that could be some signal of people's sensitivity to air, air pollutants that would also correlate with, other types of concerns around, how to set up, I don't know, the house in a more air secure way. So I guess my question is, have you guys thought about some of these behavioral proxies that you might have measures for?
Yeah, so I can talk about some of our work that we've just begun, which is, I like your idea of the proxy, but the route we've been going is actually we were contacted by an architectural firm who saw that a lot of their homes that are more high end, that are very energy efficiency, still have really bad indoor air quality during wildfires, and they're trying to figure out why. So we're actually going into these homes and putting sensors on the windows and on the kitchen fans to try and understand exactly which behavioral mechanisms are driving high pollution infiltration, even in kind of wealthy homes, to help us understand. It seems like it's going to be largely a story of people, and especially in the Bay Area, have the habit of just leaving their doors and windows open a lot of the time, at least in some neighborhoods. I don't think that's true everywhere, but that could help drive why we're seeing such high pollution for high income homes.
There's a question here for Dr. Leonard. Has your group explored the impact of provider characteristics on birth outcomes? For example, provider, birthing person, race, ethnicity, discordance, or concordance?
Yeah, that's a great question, and it's definitely an area of interest for many people. We have not explored that. There's a couple other groups that have a bit. I would say there's also a lot of qualitative work about what people experience as patients and when they have positive experiences with the healthcare professionals and when they don't. And a lot of it is about cultural humility and making it a safe and trusting experience. I'd also add it's a little tricky in data because the best we could possibly get would be the person who signs the birth certificate. And as you know, who actually spends time with a patient during their childbirth is often different. And so it's definitely an important area of work, I think. So thank you for the question.
Thank you. Other questions people have? I had a question for Jonathan, actually. I imagine you can get pretty quick kind of real-time response with the Twitter data. I'm wondering if, how quickly you think you can evaluate both, when there's new announcements that come out or some new policy, what the reaction would be, if you really, by the way people tweet and it gets in the media, if this is something that happens over several weeks and you're analyzing on a monthly basis, or whether you think there's sort of a faster evaluation that could happen of some of the impacts of different types of announcements or on either side of the debate.
I mean, I think in general, the way it works is that the people that have the most followers, which include organizations or individual, quote unquote influencers, they are taking advantage of current events and spinning it in a way that achieves their aims. So one of those aims may be to try to engage political partisans, Twitter users who essentially will retweet, will like, will spread the message. And so I think that's generally how it works. So in real time, I think fairly quickly current events become old news the next day or the day that follows. Now, the question of whether or not you can then evaluate how that affects, behaviors that we care about, like vaccine uptake, I think that's a more difficult thing to figure out. How do you actually connect social media data to behaviors? But given the way that it appears influencers are taking advantage of current events, it does seem like, and I think increasingly so, people are thinking about how do we monitor social media data in real time and make decisions or enact policies in real time.
Interesting. Thank you. Any final questions? A couple minutes. Great. Well, I have a few final announcements here for folks, but mainly want to thank everyone for attending. We also have a lot of people who later listen to the recording. So thank all of you for joining asynchronously, and thank all of you for sharing your fantastic work with us today. And as always, please let us know at PHS how we can continue to support your work. Let us know what other types of data would be useful for supporting your work. So we know that we're very interested in continuing to do that. So please keep in touch. Two quick announcements. If you're here, you've heard about the high bar for fantastic, impactful projects. And we'd love to hear what you're working on. And people who have currently funded projects are certainly welcome to submit something on a new topic, or related, but a new topic as well. So that's going to be opening up in early February. So you can start thinking about that now and put that on your calendar to put in a new Spectrum PHS pilot grant proposal. The mechanism and the requirements and what we're asking for will be very similar to what it was this past year. And then also we have a new project which is a collaboration with the Stanford Cancer Institute on a community impact research grants program. We're going to be having an information session next week on August 31st from 11 to 12. So please join us for that. And the proposal deadline for that will be October 14th. So finally, again, just a big thanks to Eileen and Sharu for making all this happen and supporting this work in such a fantastic way. And thank you all for joining. Please stay in touch.